Welcome everybody to this webinar organized by the EURO-NMD in collaboration with the EURO-NMD for Rare Neurological Disorders and the European Academy of Neurology. I'm Antonio Tavai. I work as a clinical advisor to the EURO-NMD coordination team. Today's webinar is about pediatric muscle imaging and will be presented by Professor Robert Carlier. Is a musculoskeletal radiologist, head of the medical imaging department of the Groupe Hospitalier University Paris-Saclay. He has 17 years of experience in clinical pediatric and adult muscle MRI, especially in inherited muscle disorders. And so thank you, Robert, and for sharing your knowledge with us today. The floor is yours. Thank you.
Thank you, Antonio. Nice to be with you, and thank you to EURO-NMD to have organized this webinar. Diagnosis in inherited muscle disorders is often challenging. Medical imaging, and especially MRI, could play a role in the diagnosis process. Identifying the accurate diagnosis for patients with genetic myopathies is difficult given clinical and genetic heterogeneity. The clinical evaluation, muscle enzymes, electrodiagnostic testing, and muscle biopsy often lack specificity to limit the diagnosis odyssey in the quest for the definitive diagnosis. A long time ago, whole-body MRI has been proposed for muscle disorders, but a technique was not sufficient to explore all muscle systems. For example, in this article, whole-body MRI was limited to 6 axial sections. It's not enough to explore all the muscles, and you can miss everything in muscle, and it's not a good tool to detect subtle abnormalities in muscle, especially in child when you have only subtle changes in the beginning of muscle disorder. For example, in this patient, you have a T1 weighted axial section of the lower limbs. If you only perform one section in the middle part of the thigh, you are not able to detect a subtle change in the upper part of the semitendinous muscle, which is very indicative of desminopathy. So you have to explore all the muscle, and the slices have to be continuous without gap between slices in order to avoid to miss subtle changes evocative of some diseases. Total body coverage has been developed in the beginning of 21st century in oncology field and is now available in almost all public hospitals. In this case, this patient has a right lung cancer, and metastases are visible not only in bones, but also in muscles. Here, STEER images are used and are able to detect metastases with very easily. At the beginning, the exploration was made by the body coil inserted into the magnet system. Then coverage of the body by a surface coil network appeared and permitted to obtain a better resolution and to reduce the duration time of examinations. You have the body coil network. Here, you don't have a surface coil on the patient. Classically, the examination is divided into stacks, which are fused to obtain images on the total body coverage, like this volume rendering image, and it shows that the entire body has been covered without any gap between slices. The radiologist has to adapt the protocol to the size of the patient. You have some example, 2-year-old, 11-year-old, 23-year-old. What is important is the placement of the upper limbs in the field of view in order to detect all changes in the upper limb. It's important not to cut the upper limb because you have details in upper limb, and it's important for the pattern recognition. So the technician has to be aware to have a good placement of the upper limb in the trunk or just in front of the trunk, but not to cut the upper limbs. The study is organized into steps to cover body from head to toes in frontal or coronal and axial plans. T1 weighted study, about 300 slices, takes about 30 minutes. And you add axial stir or T2 FATSAT images, and it takes about 15 minutes more in this classical examination. Number of stacks is limited in child, but the resolution has to be increased and the acquisition time for each stack is longer. It is very important, and you have to be able to detect subtle changes into muscle, into skin structure, and if you don't have a good resolution, you can miss a lot of things. The spatial resolution is one of the most important points that have been dealt by the radiologist. The size of the structure is not the same at 1 year that at 35 years. When the resolution is bad, abnormalities inside muscles are not visible. It is a clue point. Clinical experience of the radiologist is also important to adapt the examination to particular contexts, like with this child, only quiet with her mother lying in the machine with her, and the examination is performed for mother and child both. The mother has not any abnormality, and the child has very important fatty transformation of some muscles of the size. In case of severe retraction, lateral positioning and reorientation of the slices permitted to obtain a comprehensible anatomy. It is very difficult to interpret images with huge deformities, and you have to have a good comprehensible anatomy. So you have to adapt to the clinical situation. Now we have new protocols and we can use in order to be able to quantify fatty infiltration, the Dixon techniques, which can be adapted with T2 weighted sequence in order to be able to have images of fat and images of water. These images of water has the same aspect of stir or T2 fat-sat images. You can also increase the anatomic description using three-dimensional T1 slices, and with this type of three-dimensional sequence, you can perform multiplanar reconstruction in order to correct deformities, to obtain more comprehensible anatomy, or to perform 3D reconstruction in order to have a global analysis. Here is a classical examination of lower limbs. You have T1 weighted images. In T1, fat in subcutaneous area is in bright signal, like in bone marrow, and muscle is homogeneous without bright signal inside. When you use a stir or T2 fat-sat sequence, you have a very low signal in subcutaneous fat area in bone marrow. But with this sequence, you are able to detect increased water content in some areas, like here in tibialis anterior. You don't have a fatty replacement in this muscle. You are not able to detect increase of water content with T1 sequence, but with stir sequence, you can detect like edema modification into tibialis anterior. These slides are performed in the same level, and this patient has a FHD disease in early stage of inflammation of the tibialis anterior previous to fatty infiltration. Another patient with facioscapulohumeral dystrophy, but in a late stage. Here you can see a new type of sequence based on Dixon process with T2 weighted sequence. You have fat and water images, and fat images has the same aspect of as T1 weighted images, and water images the same aspect with less artifacts than stir sequence. The advantage is you perform only one examination. You don't perform two successive examinations, T1 and stir. You perform only ideal T2 examination, and you have two types of images. Another advantage is the possibility to quantify fat infiltration into a muscle with this type of sequence. In a clinical way of this type of examination, we use fat image and water image with the same aspect of T1 image and stir image. What is important is to see abnormalities into brain with water image in order to detect, for example, leukodystrophy, like in congenital muscular dystrophy type LAMA2, for example. Here it is an example of three-dimensional T1 sequence with very thin and very good resolution images, and you can perform multiplanar reconstruction and also 3D volume rendering reconstruction. Here it was not an inherited muscle disorder, it was post-enterovirus neuromyopathy. After the technical description, the radiologist has to perform the analysis of the examination. We examine all axial and frontal T1 weighted views. We perform mercury classification. As you know, mercury has perform a classification divided into 4 grades. 1 is normal, and 4 is total adipose tissue replacement. We analyzed more than 100 muscle divided into 10 sub-areas from face to legs. An example of the mercury classification for muscle of the back. Here you have a normal aspect of muscle without fatty replacement into muscle. It's mercury 1. Here you have subtle fatty infiltration into muscles, less than 30% of the muscle. It's mercury 2. Here you have between 30 and 60% of fatty replacement into muscle. It's mercury 3. And here you have more than 60% of fatty replacement into the muscle. It's mercury 4. It's not a real quantification. It is a visual quantification without any tool. So it's efficient for a description of pattern, but it's not efficient if you want to follow a disease and to detect a subtle modification of percentage of fatty replacement into muscle. In child, the fatty replacement is not always the unique or the important point of muscle modification. In this example, the fatty replacement is not into muscle, but the fatty replacement is outside muscle. The muscles are very thin, very atrophied, but there is not a bright signal on T1 weighted sequence into muscle. So if you only use the mercury classification using the fatty replacement percentage into muscle, you can miss totally the pathology, and it's very important in child to describe the importance of atrophy of muscle, like in this trapezius, very thin trapezius. So in our analysis, we use for both sides a description of the mercury classification and of the atrophy of the muscle. It's not a real quantification, it is a description. We describe the morphologic alteration of the muscle, but also of the bone. For example, in neuromuscular disorders, you have less constraint into bone, so you have less development of bones, and you can detect morphological modification of bone, for example. It's important to describe all these things. What is very important is it is a distribution of muscle involvement used for pattern recognition. When addressing a pattern analysis in a patient with unknown clinical diagnosis, it is important to observe the degree of severity of patient's involvement in order to search for the most informative muscles. Early affected muscle will be more useful in mildly affected patients. It is positive pattern, while those better preserved will be more relevant in advanced disease. It is a negative pattern. While abnormalities may be very recognizable in lower limbs for some of the myopathy, others need scanning distant regions of the body to find more conclusive features, and therefore all body scanning technique will often be more contributive. This is the case for most congenital myopathy, in particular those presenting with mutation in selenoprotein, dynamin 2, ACTA1, and nebulin myopathy. After the distribution of muscle involvement, you have some description very important. The first of them is the symmetrical distribution or asymmetrical distribution of muscle involvement. In this case, you have a very asymmetrical involvement in the scapular girdle, for example, a bright signal of the fatty replacement in the left scapular girdle, whereas the left scapular girdle appears normal. In upper part of the thigh, you can see a very asymmetrical involvement. Here it is very fatty replaced, and here it's quite normal. this type of asymmetry is very evocative of facioscapulohumeral dystrophy. But sometimes the asymmetry of involvement is not very different for each patient. In this case, you have a total asymmetry of the muscle involvement. In the right side, you have a quite normal aspect, and in the left side, you have atrophy and fatty replacement into muscle. As you can see, it is also visible in the tongue, and the fatty replacement in bright signal is very, very important. In the left side, the replacement, the pattern is very evocative of ACTA1 disease, but it's very strange to have asymmetrical distribution. But in this case, you have an explanation in the genetic profile of the patient. And as you can see, you can detect asymmetry in bone. There are morphological adaptative modification in bone. The femur is more fatty replaced and is atrophic compared to the right femur. One thing is also very important is the description of particular fatty replacement, which sometimes permit to do easily a diagnosis. And it's called muscle texture, but it's not really muscle texture. Muscle texture is a specific exploration and post-processing. Here it is only visual analysis of very grossly texture of the muscle. For example, in this case, you have huge fatty replacement of all muscle. You have joint retraction and deformities. In actual views, you are not able to detect some specific modification in the fatty replacement, but in soleus, for example, you have a band into the center part of the muscle. It is the same in tibialis anterior, the same in gluteus, in gastrocnemius muscles, and it is the same also in triceps brachialis and deltoid. You have tigroid modification, and it is very evocative of collagenopathy type 6. Sometimes you have a very, very particular aspect of the fatty replacement into muscles. Here it is like aquarelle. You are not able to do a very precise quantification based on the Mercury classification of fatty replacement into muscle, and the fatty replacement is like aquarelle. And in my knowledge, it is not visible in other diseases like than BIN1, which is a centronuclear myopathy. In other centronuclear myopathy, like dynamin 2, the fatty replacement is sometimes very particular with a punctuate aspect when you are in cross-section of the long axis of the muscle, and like a comb if you are in the direction of the long axis of the muscle fibers. In other pathology, like sarcoglycanopathy, you have some evocative muscle modification. The fatty replacement is central, and you have preserved peripheral rim around the fatty replacement, and the fatty replacement is more important in proximal part of the muscle that in distal part of the muscle. It's quite very evocative of sarcoglycanopathy, but it's not always specific, and you can have the same aspect with different diagnoses. Here you have the thyroid aspect of collagenopathy with the central part muscle preserved in all muscle of the thigh. You have quite the same aspect in this thigh, but it's not a collagenopathy, it is a calpainopathy. So be aware, it's not always specific, and your description has to be very descriptive, but you have to compare your results with all other results of the paraclinical examination and clinical aspect of the patient. What is important also is to detect missing muscles, which is not very rare in child. In this case, all of you have recognized an atrophy and missing aspect of the lower part of the pectoralis major. It is a Poland syndrome. Sometimes you have a missing muscle more detectable on MRI than on clinical examination. Here you have sternocleidomastoidean muscle which is missing. Pectoralis major are missing, which is clinical evidence. But for example, the gluteus maximus was also missing. It was not very evident clinically, and you can detect also missing muscle. Here in the thigh, you have only quadratus muscle present. All the other muscles are absent. It was a titinopathy. One thing important also is to report bright signal areas on STIR or T2 FATSAT or water images on ideal T2 sequence, which can detect active area of dystrophy process, for example. Here you are also a disease with an asymmetrical Distribution on T1. As you can see, the tongue is fatty replaced on the left side, whereas the right side is normal. You don't have trapezius or only a small part of trapezius, which is very evocative of facioscapulohumeral dystrophy, and you can detect bright signal of active areas of the dystrophic process in all these muscles. MRI can be also a good tool to detect a good area for perform the biopsy, not in an area with a huge fatty replacement, and not in a totally normal muscle, but in a muscle with subtle or slight modification, and in this area you can more easily perform a good anatomic description. What is very important also is to report abnormalities outside muscles. When examination are performed without any radiological view, without radiological control, sometimes you can have catastrophic consequence if you miss cancer, for example, if you miss severe orthopedic abnormality. It's important to have a look with the radiologist. This patient has a diffuse weakness. CK has only 2 times the normal, and the global analysis on whole body permits to detect important nodes in neck, in bright signal on stir sequence, and the analysis of the trunk permit to detect abnormality in the spleen. It was an Hodgkin lymphoma. MR is also important to detect follow-up modification in muscle along the time. Here it is an example of a young boy with a diagnosis of Pompe disease. This Pompe disease was made very early at 5 for hypersecaemia, and the follow-up every 2 years permits to detect after the 6 examination a fatty transformation of the teres major, and on stir sequence the teres major was on bright signal, and if the quantification with the Dixon technique permit to detect a huge fatty replacement with about 50% into the teres major. after the description, you have to perform a conclusion in order to give some orientation for the clinician. So you can use articles describing the modification and the comparison between diseases in child neuromuscular disorders, like in this article we have performed with Susanna Kirano-Roy, and we compare the muscle modification in all the body, and we compare the modification for one disease to another, and what we detect some clue muscle to differentiate between diseases. Sometimes one article is very useful, but not only in child, but also in adult for muscular dystrophy. It's one article made by Wadges and Dirk Fischer, and you have an algorithm to differentiate the most important dystrophy only based on the examination of the lower limbs. To have also algorithm used in specific clinical presentation, like in spinal rigidity, which is very common in child. And we have performed this article with Susanna Kirano-Roy also. And we have an algorithm to orientate to the most important pathology. And we have specific muscle to go to the right diagnosis. Now we can use also a regroupment of cohort of muscle disorders and to analyze these muscle MRI with use of intelligence artificial and to be able to detect more subtle abnormalities and to have more specific diagnosis. To conclude, all body muscular MRI allows full body muscle cartography, even in patients with severe joint contracture, respiratory failure, or carrying metallic implants. All body MRI is suitable for a large spectrum of children and adults. Muscle imaging provides an irreplaceable insight into muscle morphology, showing infraclinical lesion and selectivity. All body MRI has a very important impact in pattern recognition. For effective description, you have to group sufficient patients to have sufficient population, and it is only feasible with multi-center studies, which is always the case with rare diseases. It permits to determine the localization of the biopsy, sometimes when it is useful, to perform effective screening tests in relatives Sometimes it's also very useful, and it is not an invasive tool, so it's easy to perform, even in asymptomatic patients. More and more, the description of natural history is performed to have complementary data after clinic. Albury MRI continuously brings fresh data and will undoubtedly modify and clarify our knowledge of myopathies in the very next future. Clinical and paraclinical radiological discussion and feedback have to be performed. It's not necessary to perform all body examination if there is no interaction between clinician and radiologist, and clinician and other paraclinical physicians. And what is important is also to detect modification in skeletal system due to muscle disorders, and to detect extramuscular diseases, and first of all, to detect cancer. So thank you for your attention.
Thank you very much, Robert. I am hopeful that some questions will arise, but at the moment I cannot see any questions beside one that was an attendant was asking what was the final diagnosis of the case that you showed with the missing sternocleidomastoideus and pectoralis and maximum gluteus.
The final diagnosis was titinopathy.
Okay, so curiosity was served very well. Okay, so I think Pierre Carlier is still with us, and he'll be able to talk if he wishes to. He will be able to unmute himself and talk, but I will kick off the questions if you don't mind. I've learned a lot from your presentation, but that's not very surprising because I'm very ignorant about the subject. But I know one thing, it's that for the future of of having the means to run clinical trials, we will need to have biomarkers, and potentially the MRI offers several points where we have measurable alterations, and we can repeat the test over time. It's not cumbersome as doing muscle biopsies. So on the other hand, you say that scales like mercury or your scale for atrophy are a bit not completely objective. I was wondering if you think that some kind of progress can be made, or what type of biomarkers you anticipate will be possible in the near future, and if the artificial intelligence and post-processing progression will help with that, and how?
I'm not the specialist of biomarker and especially MRI biomarker. Pierre Carlier is more confident with this subject, but in my opinion, now we have the tool, and we have the systems, the magnet system, able to perform Dixon techniques, so we can perform fat percentage quantification into muscles in select muscles because all diseases has not the same distribution into muscle, and some muscles are more important in follow-up in some diseases than other in other diseases. So in select muscle, we can perform along all along the follow-up simple quantification with Dixon technique. Mm-hmm. It is for fatty replacement into muscle. We also can perform T2 mapping, which is important in dystrophic changes. For example, in Duchenne dystrophy, to detect the increase or the decrease under treatment of the water content of the muscle and it's now used for clinical trial. Mm-hmm. So it's relatively simple, and it can be performed, in my opinion, in a lot of centers. For intelligence artificial, in my opinion, it's not very used in follow-up studies, but it could be perhaps. What is important is to use the intelligence artificial in pattern recognition. Mm-hmm. This type of approach permits to detect not only modification in muscles, but also in skeletal. You don't have the same spine deformities in all the congenital and myopathies and congenital muscular dystrophy. And sometimes the analysis of spine deformities gives you the right diagnosis. So with intelligence artificial, you can put a lot of things into the black box and to have a lot of information, not only based on muscle alone.
Mm-hmm. Thank you. Well, I'm still waiting for more questions, and in the meantime, I will put another one, silly as it may seem. So you haven't spoken much about spectrometry, but I suppose that's an interesting field, and I'm sure you basically had to manage your time. I was wondering if there was any possibility of doing any, or if you are aware of any previous work on proteomics and spectrometry, for instance.
Spectrometry,
MRI, yes.
Yes.
Yes, sorry, spectro. Yes.
MR spectroscopy, in my opinion, is very important in metabolic and mitochondrial myopathy, but less important in congenital muscular dystrophy or congenital myopathy. It's more difficult to perform it in a young child than in adults. In child, you have to have a brief examination, not very long examination of the baby or the child move, and it's a nightmare. So simple examination are more simple to perform, but in adult to quantify the muscle fatty replacement, you can also use proton spectroscopy.
Okay. And from a clinical point, you mentioned something that is quite interesting, that is the requirements of stillness for the test. And in children, I imagine that may be difficult from time to time. So do you need to have sedation of the children frequently or not?
We never perform general anesthesia, and sometimes with a clinician, never with our sedation. We don't perform alone any sedation. Sometimes with patient, we have subtle sedation, but the pediatrician performs this type of sedation. Mm-hmm. Because you have a patient in neuromuscular fields with respiratory failure or sometimes like this, and it's very dangerous to perform it sedation alone. Yeah, but we perform examination in patient with in ventilated patient, but with intensive care unit physician, pediatric physicians, without any problem.
Okay. Excellent. So I think that I'm going to finish, and first of all, I would like to thank you very much for your collaboration and your communication. I think that it was a wonderful opportunity to learn lots of things, and this webinar will be available on the website of the EURO-NMD ERN after this live session. So it's not just about the people who were present today. We hope to reach much wider audience, and thank you very much, and hope to meet you soon.
Thank you.
Bye now. Bye bye.
Bye.